Welcome, everyone, to our webinar on the global burden of cardiovascular diseases risks focused on COVID-19 and cardiovascular population health. I'm Greg Roth, Associate Professor of Medicine and Cardiology at the University of Washington, and I'm delighted to have colleagues here today who are real experts in this area. And so we're going to have a robust and interesting conversation about this area, as well as some of the latest developments in research, and then what it means for policymaking and clinical practice as well. The speakers that we have with us today include Dr. Al-Aly, a physician scientist who directs Clinical Epidemiology Center and serves as the Chief of Research and Development Service at the VA St. Louis Healthcare System. We have Dr. Sarah Wulf Hanson, lead research scientist at the Institute for Health Metrics and Evaluation. And we have Dr. Jeroen J, Director of Non-Invasive Imaging and Director of the Echocardiography Laboratory at Leiden University Medical Center in the Netherlands. These are all experts in this space who can really bring us up to date and give us the best science related to this important topic. COVID-19 and cardiovascular disease is in an area where all of us in the cardiovascular research and area of clinical practice have spent a lot of time thinking about over the last couple of years. It's an area where there's been a tremendous amount of research and discovery, and it's an area where new findings are still coming out and having a big impact on how we're going to address both care for patients who are acutely infected with COVID-19, but also patients who are suffering from the long-term effects of a previous infection with COVID-19. And so we're going to touch on both of those, and especially this concept of long COVID. We know that the COVID-19 virus has real effects on vascular endothelium. We know that it creates syndromes that can be very challenging to care for, including critical illness, but also for patients who don't even come in for healthcare. We know that the long-term symptoms can be very challenging, and we don't yet know exactly how to manage all of them. We also know that at the population level, the COVID-19 pandemic really stressed the global surveillance system. It really challenged us to come up with better ways to collect data, better ways to measure health and the burden of infectious diseases globally. It forced us to be smarter and faster and to invent new ways to do things. And so hopefully we're going to hear about all of that today. We're going to start by first turning to Dr. Ziyad Al-Aly. Dr. Al-Aly, I'm hoping you can tell us a little bit about yourself, and maybe just start by telling us how you got into this area for your own research.
Well, first of all, thank you for having me. Really delighted to be here today. Why we sort of are interested in long COVID and post-acute sequelae of SARS-CoV-2, and specifically also of the cardiovascular complications of SARS-CoV-2. So at the very, very beginning of the pandemic, we're a bunch of clinical epidemiologists here at the St. Louis VA. We started receiving reports from patients, some from the VA and some from outside the VA, saying that we've been infected with SARS-CoV-2. We had COVID-19. We were previously young and healthy. We had no medical problems whatsoever prior to getting COVID-19. Now, weeks after COVID-19, we're having all these problems, including palpitation, including some cardiovascular manifestations. So we decided to sort of look into it, and then that was really the impetus for us to start this journey of doing research on long COVID and also characterizing the cardiovascular effects of SARS-CoV-2, both in the acute and the post-acute phase. So my lab has been dedicated to this for the past 3.5 years, and we've done work on comparisons of COVID versus flu, long COVID, cardiovascular manifestations, also many organ systems, and also characterizing the effect of vaccine and reinfections on long COVID.
One of the things that I've taken away from your work in this area is your ability to drill down to really specific conditions and to look at the relationships between past infection with COVID and specific cardiovascular complications. Can you talk a little bit about how COVID-19 impacts these different clinical syndromes, whether it's coronary disease, stroke, hypertension, or arrhythmias? Are they all similar? Are they different?
Sure, that was really very surprising to us. Like me sort of going into this field and thinking that, viruses mostly, produce acute effects, and there's really, very little to, at least in my mind at that time, I wasn't really appreciating that SARS-CoV-2 would lead to really a lot of long-term sequelae. The big aha moment we had, back in 2021 when we did our first big paper on the post-acute sequelae that can affect nearly every organ system, including the heart. And even in the heart, the damage does not seem to be specific. It's not like really only, MI or myocarditis, or it seemed to be like literally multiple different systems, even within the cardiovascular space, are impacted by SARS-CoV-2. Some in the acute phase, but certainly also in the post-acute phase of the infection, really downstream or down the road. That's really at the time was perplexing to me. It was sort of jarring. Like, why would a respiratory virus, the R in SARS is for respiratory. Why would the respiratory virus produce so much non-respiratory illness, specifically in the cardiovascular space, and also other organ systems, both in the acute and post-acute phase? And now sort of in retrospect, putting all these pieces of the puzzle together, what we've learned from my team and also from the body of research that has been published, some of by the panelists and the people on the talk today, on the podcast today, really our understanding of this evolved, and I now do not think of SARS-CoV-2 as a respiratory virus. I think of it as a multi-systemic, as a virus that can affect nearly every organ system, has complications in the acute phase, but certainly, has post-acute effects. But going back to your question, I think one of the, the hallmark of one of the, one of the major findings of the past several years is really the injury is not specific. And I'm used to thinking that, a drug must have a specific effect, or a virus or an injury must have a specific pathway, and there's specificity to the, and it only can do one or two things. But here, sort of contrary to that thinking that I had before entering this field, this is really a multi-system illness, and it's still, it's still a puzzle. Despite a lot of progress, we've made a lot of progress in understanding it. It's still, there's a lot needs to be done to sort of flesh out the mechanisms by which, SARS-CoV could lead to hypertension, and could lead to MI, and could lead to arrhythmias. And those are different things. There may be some overlap in the mechanisms, but they're not necessarily all the same thing. So a better mechanistic understanding of how does a viral infection, initially respiratory infection, lead to all this havoc in multiple, in different areas of the heart and also outside the heart is really needed.
In the cardiovascular space in particular, what has your research shown about which outcomes are most likely among individuals who've been exposed to COVID-19 or been infected by COVID-19?
So this is really a wonderful question. I think the field is really dynamic. If you ask me this question, maybe in the first year of the pandemic, there'll be one response, and then as the pandemic has evolved, the virus itself, SARS-CoV-2 itself, has evolved from the pre-Delta or the ancestral strain to Delta to Omicron. Even Omicron itself, we still call it Omicron, but it really spawned so many subvariants, and each one of them has its own phenotypic features in terms of the acute, the features of the acute illness, how, whether it's predominantly respiratory or other things, and also the profile of the phenotypic features of the post-acute illness. And add to that complexity, the vaccinations, some people in the world are vaccinated, and what we know about vaccination also reduces the risk. But not only that, it also shifts the phenotype a little bit. So not only the magnitude of risk, in these different, but it also shifts the phenotypic characteristic of what we now call long COVID, or that the post-acute phase of SARS-CoV-2. And a third major factor is antivirals. For the people who take them, that also reduces the magnitude of risk and also shifts the phenotype a little bit. So having said that, it's really hard to sort of say like there is one thing that really is really predominant. It really depends on the context. Which cohort are the people infected in the early phase of the pandemic, the second phase, or the third phase, being vaccinated, non-vaccinated. But it's very, very clear that the ones that are most impactful are, clearly we see some MI for sure in the acute phase and the post-acute phase, myocardial infarction. We also see arrhythmias. There is this whole, field, this whole entity called dysautonomia or POTS, which some people can argue it's definitely linked to the cardiovascular space, although it may be initially triggered by autonomic dysfunction or dysautonomia, but has some cardiovascular manifestations. The T in POTS is tachycardia syndrome, or the TS in POTS is tachycardia syndrome, right? So it manifests in cardiovascular space. So it's really again, if you take one thing from this talk is the post-acute manifestation of SARS-CoV-2, including cardiovascular manifestations, are non-monolithic. It's not really just one thing, and context is really, really important in interpreting the data.
So let me push you a little bit to think about the implications of your research findings. Are you teasing out mechanisms that you think might suggest potential either therapeutic options or health policy decisions that you think might either improve health of individuals who are still getting infected with SARS-CoV-2 or even potentially other viruses in the future?
This is really wonderful. Thank you for that. So I think the one unifying thread from our work, and also dovetails very nicely with all the other work that has been done, is there is one unifying thread in this sort of very complex world of post-acute sequelae of SARS-CoV-2, including cardiovascular manifestations, is that the severity of the acute infection really matters. That the risk on the relative scale, the risk increases according to the severity of infection, meaning that the risk is higher in people who are hospitalized than non-hospitalized, and highest in people who needed to be admitted to the intensive care unit. So the corollary of that, or sort of reducing the severity of the infection, as we've seen with vaccination or with antivirals, also reduces that risk profile. And that's really, there's compelling evidence about vaccination. There's emerging and accumulating more evidence about the effect of antivirals, specifically Paxlovid, and reducing that. So I think sort of focusing on reducing the risk of infection and also reducing the severity of infection by modulators such as vaccination and antiviral is going to continue to be, a key policy, a key pillar of public policy to reduce the long-term cardiovascular problems in the population. And number two, I think we all live in a world now where most people around us, including maybe perhaps us, have been infected with SARS-CoV-2 at least once, right? A lot of the people in the US have been infected at least once. So the question becomes, well, I cannot go back and revise the past and change the fact that I got COVID once. What do I do going forward? Does reinfection matter to me or matter to the population in the US and also globally to the global audience? And the answer is unambiguously a big yes, that reinfection matters. The reinfection is consequential compared to no reinfection. So we sort of think that going forward, the big things that while we all sort of live in a post-pandemic perception, that the reality is that the virus is still out there, is still infecting a lot of people, and it's still, people are still getting cardiovascular problems in the acute phase and post-acute phase as a result of SARS-CoV-2 infection. And mitigating the severity of infection is going to be key to reduce the burden of cardiovascular disease down the road. And also number two, also reducing the risk of reinfection. Now, if you put all of this in the context of future pandemic preparedness, and you ask the question, so one of the elements of your question, like how does it sort of really help us deal with other viruses, and also I would sort of extend it to the future, in terms of future pandemic preparedness, understanding how SARS-CoV-2 is really producing all these manifestations in the cardiovascular space and also other organ systems will not only help us address the challenge of long COVID and its cardiovascular complications today, it also helps us understand other infection-associated chronic illnesses and reduce the burden of chronic disease as a result of a future pandemic or a pandemic that's going to happen in the future. One of the realities of life is that pandemics are going to happen, for sure. We're going to have another one. Actually, the virus that is going to produce the next pandemic is most likely already exists in the wild, in some bat somewhere in Thailand or somewhere in the world, already exists. It just needs to spill over to humans and transmission to cascade down and produce the next big event. Will that happen in 5 years, 10 years, 20 years? We don't know. We don't know when it's going to happen. But one of the realities is that pandemics are going to happen. We know viruses produce chronic disease. I think that should be very clear from this pandemic, and also really reviewing all the evidence of the past 100 years from the 1918 flu pandemic or Spanish flu until now. And really, a core pillar of pandemic preparedness should be understanding how viruses produce chronic disease and preparing for it from that perspective.
I mean, that's really, I think, a set of important insights about what we've learned from this pandemic. I really appreciate you sharing that with us. I'm gonna move on to our next speaker, but I'm gonna reserve the right to come back to you and ask you some follow-up questions. So hold tight. And Dr. Wulf Hanson, tell us a little bit about how you got involved in studies related to COVID-19 and where that's taken your research.
Sure. Yeah. Thank you for having me also. It's really nice to be here and discussing this really important topic. So I've been involved in burden of disease estimation for over 10 years now. And what's involved in that is just estimating the prevalence and health burden of every condition around the world in every country and over time, by age, by sex. So it's this comprehensive analysis. And so when the pandemic hit, we at IHME started tracking infections and deaths, but it wasn't long before we started hearing reports of long COVID, and that term was coined, later that spring. And so as soon as we started getting these reports, we thought, okay, this is something that we will need to estimate the burden for, and how do we do that? What is involved in long COVID? Who is at risk of it? What's the symptom profile, and importantly, the severity and the health burden of the symptoms that people have. And so it was a multi-year effort of, looking at published literature, but because of the delay in, studying patients with COVID and long COVID and actual publication, we also worked with ongoing cohorts. So kind of in real time, as they were gathering follow-up data of COVID patients over time, we were getting those data and tabulating them and analyzing them together to look at these risks of long COVID. So we focused mostly on long-term symptoms, disabling symptoms of long COVID, and the most common disabling ones. So fatigue and shortness of breath and cognitive dysfunction that really impair daily functioning. And then, we also looked some into how it increases the risk of, other outcomes elsewhere of disease. So it increases risk of diabetes and increases risk of all these cardiovascular outcomes. So we didn't do those analyses because within the GBD framework, those increases would be captured under those specific disease estimations. So we focused on the long-term symptoms specific to COVID-19 episodes within people.
So I'm really interested in understanding more about data at the population level. And this is really your area of expertise. Can you tell us a little bit about how data systems to capture information about population health, especially related to cardiovascular disease and COVID-19, how did they work during the pandemic? Did they work well? What didn't work well? And what did you learn about what we should be doing differently? Like what did we learn about data for health going forward into the future?
It's a great question, because data come at us from very different places. There's health system data, there's vital registration data, deaths, and there's surveillance data happening, and then there's new research cohort studies, longitudinal studies that started with the pandemic and followed people up. So we relied heavily on those population-based surveys to track, okay, survivors of a COVID-19 episode, over time, are they experiencing long-term symptoms at 3 months or at 6 months, at 9 months, 12 months, that type of thing. And so our aim was to really be population representative and to have really quality data of detailed questionnaires and comparable symptom case definitions across these surveys. So that's one type of data. But thinking about cardiovascular outcomes in particular, in vital registration, for example. So a death that occurs is assigned, an underlying cause of death, and that's how our system tracks deaths, is assigning it to a single underlying cause of death, which is convenient for tabulating deaths and tracking them. But when COVID came along, that kind of it made the VR data much more difficult to really assess the full picture of what was going on, because if a person with cardiovascular disease died while having COVID, was it due to COVID or was it due to ischemic heart disease? And, or would they have died 6 months later, but because they got COVID, they died a little bit early. And so how to attribute those deaths, it got really murky during the COVID pandemic. And that's one of the biggest difficulties in tracking deaths, certainly, due to cardiovascular disease and due to COVID and other things too, like lung cancer, COPD. It made that coding really difficult to track.
So based on your group's research, how long does long COVID last, and how bad is it on the average?
So I'll refer a little bit to Dr. Al-Aly's answer that it depends on at what point in the pandemic you're talking about. It seems that the worst, most severe long COVID cases came, early in the pandemic, pre-vaccines, and before Omicron, and before the medications were more available. And so with Omicron, we're seeing less severe cases of long COVID and a different symptom profile. Early in the pandemic, the cohort studies that we were looking at from 2020, even 2021, we were seeing average durations of 4 to 9 months, kind of depending on the initial severity of the COVID episode. So more severe cases that needed hospitalization due to COVID or needed ICU care tended to experience long-term symptoms for many more months than milder cases of COVID-19 that didn't need hospital care. So we definitely saw that difference in the due to the initial severity. And in terms of the severity of symptoms and the health burden of them, of those cases, accounting for, like I said, the 3 main symptom clusters that we looked at, the fatigue with bodily pain, shortness of breath, and cognitive impairment. The disability weight, which is the metric that we use to account for health burden at IHME in our burden of disease work, that disability weight was the equivalent severity of long-term symptoms due to traumatic brain injury. So that's kind of how it stacks up. That's one of the similar conditions that it stacks up to. And it's, again, with our definition of long COVID, it was impairing daily functioning.
Thanks. I think it's really striking that the severity of the sequela of a COVID-19 infection can be that severe, that it rises to the level of, something like traumatic brain injury. Some of these conditions that we know are incredibly disruptive and can limit people from working or, have really long-lasting impact. Your ability to quantify that in a way where you can compare it to other diseases is pretty useful, I think. So I'm gonna move on, but just like I said with Dr. Al-Aly, I'm leaving you on the hook for follow-up questions. So we'll pause on this question about disability and symptoms. We'll move on to Dr. Bax. Dr. Bax, you're a cardiologist, you're a cardiac imager. Tell us, what was it like practicing during the pandemic, and how has that brought you into studying it?
Well, Greg, I'm going to tell you something that you're not going to expect, because I have a secondary position in Finland, and I go there every now and then. So I help them develop research. And in January 2022, I traveled over to Finland, and then I got infected myself, and not just a little bit, but very heavy. And I've been hospitalized for about a couple of weeks. And I've seen all the things that we just discussed. So I've seen the picture as a cardiologist before and after, and I've seen it myself. So one of the things that I thought was most weird was this incessant sinus tachycardia. We didn't speak about that yet, but there is a lot of in the autonomic nervous system that obviously gets quite upset. And when I was finally free to travel out of Finland and I was sort of cured, I went with my bicycle in the dunes in the Netherlands, and you take these little hills. And then all of a sudden I noticed that I could not get up there. And it was that moment that I realized that I had this post-COVID tachycardia syndrome, which we published about myself with colleagues in the American Journal of Medicine, but I never thought that I would have it myself. So realizing those things, I had all the things that were discussed also about forgetting a lot of things. It took me a year that I had this sort of brain fog, that all of a sudden at a certain moment, I could not remember what we were talking about. So I got very worried. We did an MRI and we did a CT scan, and the MRI was completely clean, but it kept going for about a year. And then all of a sudden, from one day to the next day, nothing anymore. Everything back to normal. So I wanted to give you that as a starter. So we published also this incessant sinus tachycardia syndrome quite early, actually during the time that I was in the hospital. And then you experience those things yourself, which really puts you in a totally different position than the physician looking at that and all of a sudden experiencing that yourself. Also, that's very annoying that I was halfway the discussion completely lost what we were talking about, and that also from one day to another completely gone. We did an MRI of the brain, we did a CT scan of the brain, we did a CT scan of the vessels actually to see, because I was also afraid what we're going to talk about probably is coronary atherosclerosis. And interestingly, I had a calcium score of 0 and not any coronary atherosclerosis. So it was good news, but it gives you a picture of the things that can happen to you and how long it lasted. And then from one day to the other was completely gone. So let's go back to your questions, but I wanted to give you this because for me, it changed completely, because you look at patients and you see all that, and all of a sudden you have it yourself and you start to look very differently at things.
Well, I appreciate you sharing that with us, and I agree. I mean, as a cardiologist, when you have a condition yourself or a family member has it, it really adds this layer to how you think about things and makes it very personal. Not that, what our patients have isn't personal for us, but it's not the same. And I'm glad you're doing well. And I think it's fascinating that you felt that your symptoms resolved so quickly. So I'll maybe ask you to think a little bit about, what you know on the research side and in terms of mechanisms. It sounds like, something that can be so labile can occur and start very quickly and then can resolve very quickly. There must be some insights into mechanism from that, and I'm curious what you think about that.
Yeah, I think one of the most important things is the inflammation factor, and that is what we see all the time when we look at these PET scans, and so that there is areas of inflammation. And I think it's not specific for this disease; it's specific for a lot of diseases, or aspecific, I should say. But it's the inflammation that really drives this thing, in my opinion. There's also accelerated atherosclerosis, but again, that's why I told you about this. I didn't have any of that. So it presents in very severe cases, and it presents in cases where you see nothing. So that's what makes it so intriguing, that you can be all the way from A to all the way to Z. But changes in atherosclerosis, we've seen a lot. We've also seen a lot of all these thromboembolism problems. These are the ones that we see a lot. But also in the PET scans on the brains, you see a lot of things. And the interesting thing is also that sometimes you see a lot of abnormalities, but it does not translate in functional consequences. And sometimes you see very little abnormalities translating into extremely severe consequences. One of the things is also these MRIs that were done in the myocardium, and people were thinking that you would have inflammation situations and fibrosis or scar development. There has been a lot of discussion about it. I think that there is patients where it's not completely reversible, and we've also seen cases where it's completely reversible.
I think it's really interesting that you're touching on different modalities for imaging and diagnostic tools that we have in cardiology. And I want to dig into this a little bit with you, because you touched on PET, you touched on MR, and oftentimes in cardiology, we think about diagnostic evaluations in terms of imaging related to structural abnormalities versus perfusion abnormalities. And oftentimes we don't have, the same kinds of tools for abnormalities related to inflammation. We can look at circulating biomarkers. We can tag PET to look at inflammation sometimes, but we don't do that routinely in clinical practice the way we, look at perfusion and structure. And so I'm curious if this, when you think about your toolkit, when you are seeing a patient who has long-lasting symptoms following a COVID-19 infection, and you are thinking it might be part of this inflammatory syndrome, we're not going to necessarily draw a TNF alpha level, or maybe we are. I mean, you tell me. What are the tools in your toolkit? What do you bring to the bedside or to your clinical practice to try and dig into this?
Well, these are complex diseases, and so I'd like, therefore, to use the much more advanced techniques that we have, such as CT, CMR. These are the tools that bring us a lot, and specifically CMR, but also the PET scan. They can help us differentiate between burned out inflammation. Does it change into fibrosis, which is very easy to detect on CMR. You can see the big scars quite easily. The diffuse fibrosis we don't see so easily, but we can calculate that with the so-called T1 mapping. And I think these techniques are giving us a lot of insight in the damage that is there. What the PET scan is very good for is this acute inflammation, the chronic consequences of the inflammation. Again, does it make scars? Does it leave fibrosis? I think that in a lot of diseases, including this one, the fibrosis formation is the final common pathway. That is what the end product usually is. I think also these fusion imaging, which we did not speak about yet, is extremely important, because the fusion imaging gives us the physiology, such as blood flow, which you were hinting at, perfusion at the tissue level. So this is not the big blood flow. This is not how much blood goes through this coronary stenosis or so, but this is really looking at the perfusion level of the tissue, the microvasculature, so to say, which is very important also in this disease, we've learned over time. So I believe that this PET and CT and CMR are the big ones, but the best one, I think, is the combination of PET combined with CMR. Then you get the acute fibrosis, you get the chronic fibrosis from the more anatomical things from your CMR, and you get the inflammation component on top of that from your PET scan. And there are certain tracers that very nicely nowadays highlight what is an acute inflammation. That doesn't tell you anything about the pathophysiology, but you see that it is happening in this organ that we're talking about. We've seen these abnormalities in the heart, and we've seen a lot of these abnormalities in the brain.
Yeah, it's really interesting that you frame it that way, because in many ways it moves this syndrome into the same space as conditions like cardiac amyloid or cardiac sarcoid, where we've struggled for a long time to try and come up with the right sort of protocol and imaging modality. And there are these sort of occult, slow-burning conditions where they often present with very non-specific symptoms. And so it sounds like you might be adding sort of the long-term effects of COVID-19 to that group of sort of not completely understood inflammatory or infiltrative conditions.
Exactly, and especially this advanced imaging can tell us what has been cured in a way. That means probably fibrosis formation is probably the final common pathway, and what is still active. And it's this combination of these scanners. If you do them 2 in 1, that's probably gives you the best co-registration, and you get really a good picture of what's going on. I think, as you said, it's fascinating because we see some lesions almost completely gone, and some lesions that were relatively small to start with, and then over time got bigger, made more fibrosis, made bigger scar. But I do believe, as I said before, that once you have the fibrosis formation, that is a non-reversible point, I think.
I think it's been an amazing sort of range of topics we've covered here, from the clinical epidemiology of the sequela of the infection to sort of how we measure it in populations and how we measure disability due to it, to these very advanced imaging techniques that we may need to employ to understand it in our patients. I'm going to come back to each of you for just one last follow-up question before we wrap up. I'll let you throw in whatever comments you want, but I think the framing for my question really is, from your past research, your ongoing research, and the research that you're hoping to do in the future, what's the message that you would like the practicing clinician, the cardiologist, the nurse, the nurse practitioner, the person at the bedside who's taking care of patients, with this condition? What do you want them to know about the science of our of COVID-19 and long COVID? I think just go back and start with Dr. Al-Aly again.
I think if I leave one message to the audience is that infections are not inconsequential, and viral infections are not inconsequential. If there's one thing we learned from the COVID-19 pandemic and SARS-CoV-2, that it can produce chronic disease, including cardiovascular disease. And this, we generally tend to trivialize infections and say, oh, this is really like the common cold, or this is like the flu, as if the flu is a trivial and inconsequential infection. It's actually not. It can also lead to chronic problems, so I think we need to take a deep look at the idea that infections can lead to chronic disease and understand it better. And I would argue, even take it further, that maybe much of the driver of chronic disease, including metabolic diseases like diabetes and cardiovascular illness and neurologic complications, probably is also much of it is really probably driven by infectious etiologies. And we've all sort of are familiar with the literature that pollution, PM 2.5 in the air can lead to chronic disease. And I sort of liken it or analogize it to that concept that pollution can lead to chronic disease. I think becoming now more and more aware that infections can lead to chronic disease, and we need to evolve that understanding and be able to really measure like with Sarah's help and you guys all help, and IHME and others measure the burden of disease that's attributable to infections. And I think that's really going to be a very important step for the next decade. And again, it will not only pay dividend in helping us understand the consequences of this pandemic, but also really better prepare for the next one. And maybe if I want to add one thing, I mentioned on the call that severity of infection really matters, but also want to mention that, yes, the risk on the relative scale increases according to the severity of infection, but because most of the world, when they got infected, had a mild infection, even a smaller relative risk of mild infection, a small relative risk of experiencing long-term complications will translate into much, much larger absolute numbers. As a matter of fact, most of the people around you that are suffering from long COVID would have had mild infection, not severe infection. So it's very important to distinguish sort of the scale of the severity and the risk on the relative scale versus the absolute scale here. And again, thank you for having me. This is really great.
Yeah, I mean, thanks for those insights, Dr. Wulf Hanson. From your work on population level disability and burden, What do you think the message is for that healthcare provider who's seeing this patient with these persistent, sort of intractable symptoms, maybe?
Yeah, I think one important message is to take them seriously, because even like Dr. Bax mentioned, like sometimes tests show up normal, but they're experiencing symptoms, and so a lot of these long COVID symptoms are rely on the patient's experience with them and their day-to-day functioning, and there's not a one single diagnostic test for long COVID, and there's not a silver bullet treatment for long COVID either. It's this complex condition, and it can be really confusing and really hard for a patient to walk into something that they don't know anything about, and where symptoms come and go and they don't know how long it's going to last. And so I think being listened to is big, and keeping up with the ongoing research about treatment and trying different things. And like I said, the average severity is less than a year for many people, but there is a proportion that go on to have symptoms for more than a year, disabling symptoms where it's hard to walk upstairs, or where they have memory problems like Dr. Bax mentioned, or are unable to care for their loved ones if they're a caretaker, or it impacts their job. And so that portion of long COVID patients that become chronic sufferers of long COVID, we as a research world need to figure out how to support them, how to prevent those chronic cases, and I think reducing initial severity is important, and also not dismissing a mild case of COVID. And even there's some kind of early research that asymptomatic SARS-CoV-2 infection can lead to long-term symptoms, which can be really hard to pinpoint the cause of, whether it's some other infection or an asymptomatic infection or these things. It is really murky. And so I think a lot of times we just have to take the symptoms at face value and work from there.
Dr. Bax, you get the last word here. What's the message from your research, from your clinical experience, to that provider at the bedside who is seeing someone who may have this syndrome?
Yeah, well, thank you. And what I think is very important is that we learn to better understand what exactly is happening. There's so many things that we still don't know exactly how this works or how that works. But the non-invasive imaging has brought us a lot. And I'm talking specifically, as we said, about these high-end imaging machines, the PET scanner and the CMR, the combination of scar fibrosis that doesn't go away anymore, and the acute inflammation and what is reversible on that. I think that is important. So if we want to make steps forward, we have to better understand, one, the disease, two, what are the most important diagnostic criteria, what I just said about the atherosclerosis we spoke about function, we spoke about fibrosis. We need to understand that better, and we need therapies for that, because the fibrosis as it stands now is not really treatable. And if it's big fibrosis, it's going to result in dysfunction of, let's say, contraction, something simple. And but it can also be a source of arrhythmias. And so I think we need better understanding, eventually resulting in better treatments. Because once we understand, we can probably go in the direction of developing some treatments and to take away these probably quite dangerous complications.
Well, I really want to thank all three of you for joining us today and for sharing your experience, your research, your personal experience with the pandemic, with SARS-CoV-2 as an infection, but also as something that creates real significant sequelae for patients after their initial infection, and is having impacts at the population level, and needs to be understood by policymakers and health systems so that they can help take better care of these folks. So thanks to each of you. Thanks to the Journal of the American College of Cardiology for supporting this webinar and creating this platform so we can try and communicate some of the important research that all of you are doing in this space. And I appreciate everyone who's joined today to learn a little bit about this important topic. Thanks very much.